50% distribution for distance, 35% for near, and 15% for intermediate. But however, one of the drawbacks was that it was pupil dependent, and in Indian patients being myotic, pupil being with senile meiosis, this IOL gradually phased off. In the next series came the Resume multifocal IOL, where it had 5 zones. Zones 1, 3, and 5 were for distance zones, and zones 2 and 4 were for near. And the zones 1 and 3 were expanded so that 30% of the incoming, 60% of the incoming light was for distance. However, obviously the major limiting factor was halos and contrast loss, and this limitation was reduced with bilateral multifocal implantation. Taking bilateral summation as a beneficial factor, Acritech came up with a combination, the 733D and the 737D, that is the near dominant and distant dominant, and simultaneous implantation led to around about 100%, which was a little benefit from this. But obviously, not many patients preferred bilateral implantation. Then after that, we had the newer generation IOLs, in which the first one was the Technus AMO. First, it was a 3-piece, and then after that, it came on to the more recent 1-piece IOL, and this was a wavefront designed with a prolate anterior surface to neutralize spherical aberration and a posterior surface which had 32 diffractive rings to help multifocality. Alcon took it one step forward in the sense that they apodized this diffractive surface. So we all know what is apodizing it. I don't require to tell it. But there were 12 rings on apodized rings on the anterior surface, and it had at the IOL plane around about 4 diopters, at the IOL plane near ad, and the 3.2 diopters at the spectacle plane. Two models which we know are in vogue. One is basically more producing the night glare and halos. Various Indian clones copying the above two platforms, that is the AMO and the Alcon platforms, came up, but the inherent disadvantages do remain there with all the diffractive IOs. So let's look at what these disadvantages are. Going in very quickly, we all know that the disadvantages of the or the minuses of the lens were reduced brightness and contrast, disturbing glare and halos, questionable intermediate range, and obviously, if there is an off-center, slight off-center decentration, it will lead to disastrous consequences, sometimes disturbing aberrations. So, are we ready? Are we ready to give this to our patients? Were we ready? This was quite some time back. So, were we ready to give this patient? Am I looking at giving a patient difficulty in driving, reduced contrast for watching television and mobile, poor computer this? So obviously, we had to, looking at all these disadvantages, we used to work up ideal patients for a successful outcome. Since the lens technology was a limiting constant, we all had different protocols. Let me share with you my protocol, some points of my protocol, and I consider this imperative for a successful outcome. A good ocular examination, a good history is first of all very important. That yes, the history is vital. Some points to highlight in the history is that the patient should not have unrealistic expectation, but the desire for multifocality is important. It is an absolutely no for night drivers and patients who are working at a specific distance, like say tailors or painters. I found it very difficult to get the multifocality to their distance. It's also important to rule out anisometropia and amblyopia, which can sort of hit you under the belt. A good ocular examination is very critical. I for a long-term outlook, I refrain from taking up these cases. Like you see, early glaucoma cases, no, absolutely no. Diabetic retinopathies, no. If I see brucin like what I've shown you in the photograph, say no. I don't put multifocals for them. A sine qua non for accurate for me for a successful outcome is I lay a lot of stress on this is an accurate IOL power calculation. My protocol for this is very stringent. I have both the biometries. I have the immersion as well as the optical, and in the optical also I have both the step source and the normal optical biometer. I use these in my armamentarium. I also do a manual keratometry for everyone, and I do this with two technicians. They do it independently. They do two technicians. I compare both the reports. They are like blind checks for both of them. And after getting the two and comparing, then I put it on the Barrett's or the SRKT, and then add my surgeon factor to get touchwood a near perfect IOL power for most of these patients. Obviously, there is another parameter which I use for good refractive outcome. I use the eye trace. I don't have any financial interest in this, but the eye trace uses a ray trace technology, differentiating corneal aberrations from internal aberrations, and hence helps in differentiating or classifying for me what are ideal patients with multifocals. Of late, this has become an indispensable part of my workup. Let me just tell you, enumerate what are. Let me a quick glance as to what all I look at. So the first factor which I look at is angle alpha. We all know angle alpha. Angle alpha is the angle between or the distance between the that is the center of the capsular bag and an anatomic center of the capsular bag where the IOL is going to be positioned and the visual axis. So you can see in the photograph down that the red point is the visual axis center and the blue point is the limbal center. And you can see in the photograph up, I put a multifocal lens and just as a schematic, and you can see that the anatomic center is in the center, but the visual axis comes onto the first ring, and this can have potential unpleasantness to the patient. It can lead to a very unhappy patient. So let me show you some. Let me show you an eye trace chart which I have, and you can see that this patient I have the angle alpha I have highlighted in red. It is on the right hand side of the slide. You can see it's red. uh, that shows that the angle alpha is above 500. So what does the eye trace do? It actually flags it as red if it is above 500 microns. 200 to 500 it is flagging it as yellow, and less than 200 it is green. Now this is very important for biometrics, because we generally don't do, we just generally go and interpret. Biometrics can also recognize whether it is a fair angle alpha or not. Let me show you another one here. This one I have highlighted that this is green. It is less than 500 microns, and obviously you can see the on the right side. You can see that it has given me some lenses also. The next factor which I look at is higher order corneal aberrations. So I had a look at angle alpha. I'm having a look at higher order aberrations. Uh, the higher order aberration should not be more than 200 microns. Now, this is very important because for multifocality, you should have a good optical quality of the cornea. And if the higher order aberrations are greater than zero point 0.2 microns, then it goes as a negative. I take it as a negative for a premium multifocal. So let me show you an eye trace chart for this. Now, this patient, though you can see that the corneal higher order aberrations are less than zero point 0.2, it is actually 0.04. But this was a patient of Fuchs endothelial dystrophy. Now, where how if I look at the slit lamp, I see a cornea which is not looking very good, but I see a corneal. That's why I put this slide specifically to highlight the fact that yes, if we do get corneal aberrations which are more than zero point 0.2 microns, less than zero point 0.2 microns, we select no. Clinical examination is very important. Obviously, in corneal opacities and in dystrophies and degenerations, frank degenerations, you're going to get corneal higher order aberrations which are higher. So next, let's take on the next factor what we look at, and we look at the corneal spherical aberration, and obviously the aim is to neutralize this to get a sharper image. I prefer to neutralize it. So let me share with you some charts which are used for planning. Now you can see on the left hand side of the chart is the Chang analysis, and I use this to see the corneal aberrations to get a look. I also obviously look at trefoils, both horizontal, vertical, and comas, horizontal, vertical. And on the right side, yes, it you can see on the right side of the chart as I move in, you can see that it has got an IOL checklist, and here you can see that it has the angle alpha is more than zero point 0.5, so it has given me an advanced balance curve, that is an aspheric IOL and a spherical IOL as a lens, as an IOL of choice. I show you another chart where here this one has actually it is very well demarcated that yes, the everything looks okay on the checklist. So it's the astigmatism is around about 1 diopter. So it shows a toric premium as what the artificial intelligence of this machine would help me in. Obviously, this is important for me. It helps me tell a patient that look, a machine is telling you. Sometimes patients listen to machines more than what they listen to us. Obviously, all these investigations would be ineffective without a perfect surgery. One, from all the masters, I have three very eminent masters on top. I have learned a lot from them. I have learned that you have to get robotic. Obviously, I don't have right now, I cannot afford buying a robot. So I have learned to be robotic. And we all, I guess, are very well skilled today in cataract surgery. But
Excuse
one
me.
factor which I would like to put in is I use the Purkinje images to center to check the centration. and that is for me is very critical. I use Purkinje image 1. In the Lumira microscope, you do have the 3 lights help in this.
Dr.Anis?
So what's the bottom line? The bottom line is, here we had patients, when I used to work up patients, I used to have around about 50% patients who were, I would classify as ideal patients for a multifocal. And when I would sit down and explain to them the drawbacks about the diffractive technology and the refractive technology, 30% of the patients would drop out. I would be left with 10-20%, and these patients generally would be very happy. An occasional sting in the tail would come in, and but with good counseling and time, these patients would settle down. So where do we stand with the diffractive technology? With the older technologies, are multifocals dead and buried? Are multifocals stand to stay? Will intermediate range be answered? Will some what will be the ideal? Can we find a lens which is akin to a human lens? I leave that to the next speaker, Dr. Pranay. Thank you so much.
Thank you.
Thanks. We take a moment to welcome our scientific chairman, Dr. Ragini Madam, and Dr. Preetham.
Hello, Dr. Ragini Madam.
Good evening. Good evening. Hi. Good
How are you,
evening,
madam?
Sir. Fine, thank you. Good evening, Keki sir. Good evening, VC sir. Good evening,
Good evening, Keki sir.
Good evening.
Good evening, ma'am.
Good evening.
Dr. Preetham has also joined us.
Hi, Preetham. The experts and the chairman of the session, any comments before we can start Pranay's talk?
So I think the basics have been made very clear by Anis about the diffractive, refractive type of IOLs. So it's now a good time to go to the advanced IOLs with the EDOF and the others. So I think Pranay can probably start.
Sure, sir. Pranay sir, are you ready?
Yeah, I'm ready.
Yeah. Please share your screen.
I can
Doctor,
still see that Anis is.
I'm getting off. I'm getting off.
Yeah.
Thank you so much, Anis.
I'm off. Thank you, madam. God bless you, ma'am.
Thank you. Thank you. God bless us all.
I'm staying right behind JJ. So JJ is, I think, sir is up and strong. He's holding fort.
Thank you. Thank you so much.
Hi, everyone. Can you hear me well?
Yes.
We can hear you,
Go on.
Go ahead.
Hi. I thank BOA. I thank Swapnesh and my dear friend Preetham for giving me this opportunity. And thank you, Anis, for making my job really, really simple. So I will stick my talk. I'll just restrict my talk to what I use in my practice. That's the premium multifocal IOLs. So in my practice right now, the types of premium multifocal IOLs which we started with was the regular or the bifocal IOLs, then the trifocal, the EDOF. I'll make a mention about the EDOF multifocal as well, and the toric. But toric, I think, is going to be taken care of in the next session. So we start with the regular ones. The first one that we, the so-called premium IOLs in the present era that we started using was the Alcon Restore. It was available at +4, +3, +2.5, and then came the Technis multifocal, the one-piece Technis multifocal, which also started with +4, +3.25, +2.75 is not available with us. Just a mention about Restore. +2.5 was given mainly for driving, golfing, and shopping, and tennis playing, etc. +3 was given mainly for reading and tablet viewing. It had the anti-rapidize and the posterior optic surface, which has been very, very well explained by Dr. Anis. And most important is Alcon now does not promote Restore. So my practice with Restore is 0 at present. Technis multifocal is still a very good lens. It gives you the anterior aspheric surface with a good diffractive posterior surface. It does have slightly decreased contrast, but it gives a very good asphericity, and it's a pupil independent optics. Now, this is where, when I started my premium multifocals, this is where I shifted on. This is the point where I shifted on to Technis multifocals. So you can mix and match. So +3.25 is something that you can put it in the dominant eye, which is very useful for the multimedia work and the regular work. +4, you can put it for the reading and the knitting. So this is something that worked very well in my practice. The technology which is being used in the present generation bifocal and the multifocal IOLs, apodization is nearly given up now, but asphericity, reduced aberration, diffractive zone minimization, adding more height steps, and reducing of glistening. These are the things which make the newer generation IOLs the more premium IOLs. So we shift on to trifocals, because the time the trifocals came in with Zeiss, and then of course now it has been followed up with Panoptics. So are they our first choice? So let's see how good they are, and then we just go on to my choice. So first generation, second generation, and third generation. So the third generation or the trifocal IOLs, or typically what Panoptics gives, is, as you can see, there are 3 add powers over here, as opposed to the 2 add powers and the 1 add power. The characteristics which the Panoptic says is the enlighten or the enhanced light energy technology, and a continuous range of vision which gives you between 40 and 80 centimeters. So basically, apart from the distance, it gives a brilliant view of the inner and immediate vision. So it's quite useful for computer work, smartphone use, cooking, and playing games. Advantages of less as compared to the larger zone size, which compromises in the distance vision, whereas slightly larger than 4, which compromises the near vision. So it sort of just gives you the optimum size of that particular zone. So it gives you the advantage of high light utilization with a good, comfortable near intermediate apart from the distance vision, less dependent on pupillary size. And there is a platform which all of us know since almost more than 2 decades. That's the AcrySoft platform. Everybody knows how to insert an AcrySoft lens. So there's no extra skill required in inserting this lens. Then came, before this was, of course, Zeiss Italiza was introduced. And the only difference over here is that it has the hydrophilic acrylic, which is 25% with the hydrophobic surface. It has a plate haptic design. I'm only going through the difference between the 2 lenses. It has a disposable preloaded injector system. It came with that trifocal central and bifocal periphery, plus 3.3 near add and plus 1.66 intermediate add. There's again no glistening, good mesopic vision, less incidence of glare and halos. But they all do have glare and halos. So with these disadvantages, where do EDOF stand right now in my practice? So there are certain disadvantages which we know, which are there for multifocals, which are there for even the trifocals. That's loss of contrast, halos and glares, and the discrete and the continuous vision. So I will talk about only one EDOF which I'm using, EDOF multifocal which I'm using, that's Symphony, which gives good continuous range of high quality vision with a minimum level of disturbance and high level of patient satisfaction, because it gives you the Technis technology. So we've been inserting Technis once since a very long time. So again, insertion is not an issue. And the proprietary HLED design and the proprietary achromatic technology gives you a good range of vision. Most important thing for me, as far as Symphony is concerned, as far as the choice in Symphony is concerned, I feel it's the most forgiving multifocal IOL as of now. So it gives you a good aspheric surface with a low refractive index, a good material with minimal chromatic aberration, minimum light scatter, and tolerance up to astigmatism of +1. That's really something that the trifocals do not give you. In trifocals, you have to be bang on. You have to be very, very accurate. So I'm not going to go into any more technical details, but I would want all of us to know that how do we choose wisely? So there are certain patients which we are not going to choose. I'm not going to go into the detail of all the scientific and all the way in which we are going to analyze the patient on different machines. I'm only going to give you the practical tips which I use in my practice. So there are patients who are not opposed to wearing glasses. There are patients who in fact enjoy wearing glasses. Those who are impatient, unwilling, unrealistic expectation with pathologies, don't do that. There are very good candidates. There are patients who come and they are totally motivated, sportsmen, theater persons, avid readers, relaxed personality, and very well counseled. So these are few points which I include in all my counseling for all my multifocal patients, which are premium category, because all of them have some sort of, they come with a notion that, I'm going to be replaced by a lens which is just absolutely natural to the natural lens of the eye. So that's the first thing that we tell them, that multifocals IOL do not replicate natural lens functions. and they do not start working immediately. There is a period of adaptation which can go up to 6 months. Glare and halos will definitely be part and parcel, but they will reduce with time. And I never guarantee them a glasses-free 20/20 vision, but I tell them that most likely you're going to get it. But in case one does not get it, then there is always an option of glasses, or we have machines with which we can correct the astigmatism. Important thing in counseling is the post-operative follow-up and the staff training as far as our center is concerned. In post-operative follow-up, we have a dedicated room in which a multifocal patient is seen before and after. Suppose you have different rooms in your clinics, and if each room has a different chart. So there is one room in which the patient is seen on the same vision chart before, and the patient is seen after implantation. So the patient themselves can compare. They can compare results to illustrate improvement. You keep on asking them about how their hobbies, how they have changed their hobbies, before the implantation and after the implantation, how is the change now? And make them realize that they are getting better, each and every patient. But in spite of them, if some of them are unhappy, then you can just demonstrate the power of the IOL by just putting minus 2.5 in front of the spectacle lens, and you tell them that this is what the lens is doing. If you had not implanted this lens, then this is what the monofocals would have done. And an important thing that I want to mention about the staff training, we understand that the patient is going to spend hardly 10 to 15 minutes with you, but is going to spend good 1.5 hours with the staff outside. So that each and every staff who's handling these premium patients has to be motivated, and they have to understand that they are doing this job in which they are going to change patients' lives. So they are discuss the benefits and challenges of this particular type of premium category of lenses and the patients. The criteria and assess of patient candidacy has been explained to them. We do get professionals to train them from Alcon and J&J. You can tell your staff that you depend on them, and we keep on telling them that we appreciate your role. One last mention about the Technis iHands, which is an EDOF monofocal. It does not actually, I should not have included, but this is something that has really featured in my practice of late, because it has a wavefront optics and refractive technology. It has no rings. So power increases continuously from periphery to center without any steps, with a continuous higher order aspheric surface, and it enhances intermediate vision. So there are quite a few of the monofocal patients, who are opting to go for these lenses, because there are patients who say that TV watching, including subtitles, is very good with this lens. Reading on computer and tablets is very easy. Walking on uneven surface for a patient who's very old, they find it very easy. And conclusion, I would give more of suggestions than anything else. Looking at the scenario in which the Panoptics and Zeiss trifocal have started reducing their cost, I would still consider that they are my first choice as of now. Especially chauffeur-driven executive computer users, the one with the desk job, they should be the first preference. Whereas when you can mix and match, so if you can put symphony in a dominant eye and a multifocal or a trifocal in a non-dominant eye, you can make quite a few of those patients who drive at night, who do the job as the homemakers, sportsmen, people who drive themselves, they are all happy with this kind of combination. And iHands is for avid night drivers. The patients say that I cannot live without night driving. Okay, iHands is the only option, or then they can choose monofocal. And Toric should be used much more in our practice to increase the outcome for the better outcome of our premium category of multifocal patients. So in all the category, we have the regular trifocal as well as the EDOF Toric, which will be discussed in the next session. So thank you very much for the patient listening to me, and I hand over to Vaishal and Suvira for the next discussion. And thank you again, BOA, and thank you, Swapnesh.
Thank you, Pranay.
Thank you, Pranay.
Yeah, I think we can just open, Dr. Mehta, we can open it for some discussion about both trifocal as well as the EDOF. And,
absolutely. Absolutely. You can hear me?
There be any preference?
Yes, sir.
Can hear you, sir, loud and clear.
No. Okay. No, I think the most important point in this lecture, previous lecture is very simple. The most important instrument you can purchase in your entire armamentarium is an excellent guide who can guide the patients down the line. The lady or the man who is going to guide your patients is most important. And I think more time needs to be spent with them rather than with anybody else. because they are the final answer. Now, the interesting thing, is when we turn around and talk to patients and we tell them that you need to go in for a multifocal. My practice is almost 80% multifocal. I prefer not to put monofocals if I can avoid it. But every patient is cautioned and advised in advance that you will see rings. It's part of the physical nature of the lens, but you will no longer notice it. I explain to them by putting them under a tube light on top and saying, you can see the tube light, you can see the reflection on the glasses, but after some time you don't notice it, which is exactly what it is. I tell them rings are permanently there, number one. And number two, the most important advantage of their seeing rings is they know that the lens is well centered. Tell them that if the ring is perfectly round and is centered, your lens is in perfect position and they should look for it. Interestingly, when you convert a disadvantage to an advantage, the patient is happier for it. The last thing, of course, is very simple. We need to know exactly which sort of patient. There are some patients who still will go on to a monofocal despite whatever you would like to tell them. And on the other hand, you would prefer them to be on a monofocal because with a multi, they are going to give you trouble more and more. But point does remain that you can explain to these patients and tell them that at present, important step, do they wear multi, do they wear bifocal glasses? You see, the biggest problem, the reason why people are resistant to go to multifocal lenses is because the present spectacles which they wear, call them progressive, are really not progressive. There are 3 different zones, and the intermediate zone in the middle is a joke, really. And so the point remains that they think that the trifocal glasses are going to be like that, which they are not. You tell them they are trifocal for every single point. Once they appreciate that, this is a different story. And then finally, you have to tell them that if you want to be dependent on glasses, you can. There are some people who will say that I don't think my face looks good without glasses. In which case you tell them you can still wear glasses. The numbers need not be there. So by and large, I think it is mainly the person who explains down the end of the line, which is important. And as he has accurately put it, as Pranay has very accurately put it, spending an hour with each patient is most important. Biggest importance is that patient must know, okay, these are the advantages, these are the disadvantages, this is why people go for it, this is what you will feel in the first 2 or 3 months, and adaptation is a factor which takes time. Not everybody adapts identically. Important other step is that explain to them that multifocals work best when the second eye is implanted within 3 weeks. It is a 3-week criteria which makes life very easy. You defer the implantation of the second eye for 2 months and 3 months, you have a headache sitting on your hands. So tell them, you want to do multifocal? Great. But we advise it within the next month, you will complete both. So plan for both, don't plan for one. And the other last thing to tell them is that all these lenses have, say, 50% for distance, 30% for intermediate, 30% for near, 20% for intermediate. But it will only become 100% when both eyes are implanted. Multifocals do not work in a single eye. So I'm always very hesitant to put a multifocal in one eye and put a mono in the other eye. Neither is he happy with one, neither is he happy with the other. And when he then talks to patients, you don't get referrals from them. So the important thing is you need to talk to them, explain to them what they are going in for. But properly explained, you have a happy patient. I don't have patients who come and crib. I have a room full of patients and they start cribbing. So मेरी तो हालत बुरी हो जाएगी. The point remains, that's what you need to do. Talk to them. That is the most important.
So do you prefer to use EDOF also in both eyes with a micromono or trifocal? What is the preference?
My personal preference is a tri, always.
Not
EDOF. No. EDOF I try to put only when a person says, I do not want to see rings at all. Number one. And number two, particularly a patient, for example, who's a golfer. For him, EDOF is fantastic. A person who just wants to drive at night, EDOF is great. But if a person says he wants to be able to read and work on a computer at the same time, you are not going to get, despite whatever has been written, no matter how much people talk, in the end, they are not happy.
Yeah. What about VC? What is your preference? Do you
Well, my preference is only trifocal lenses as of today. We first shifted to the Zeiss trifocal when Panoptics was not available, and now the Panoptics, we have given up all of the lenses, the EDOF and everything. the two lenses, the Zeiss as well as the Panoptix, both function extremely well, except that the material design and the platform on which they are constructed is different. So my preference goes for the Panoptix. And secondly, if you want to do a multifocal or a trifocal lens, investigate as much as possible, talk as much as possible. So in addition to what all things that have been enumerated, the dry eye evaluation is a must. OCT macula is a must, because a subtle kind of an ERM can be missed in a routine indirect ophthalmoscopy examination. And obviously the eye trace and everything has to be used. So my point is, whatever instruments you have in your clinic, better utilize them before the surgery. And then, if you utilize them after the surgery is over and the patient is unhappy, and you find out from your own OCT machine that the patient has an ERM, it cuts a very sorry figure in front of the patient.
Yeah. So I think
I fully agree with VC. OCT prior any trifocal lens is mandatory, not optional.
Yeah.
But let me stress one thing more, which people don't seem to bring out. 3 months after the surgery, you have some patients who turn around and tell you that my vision was very good, but now it seems I'm seeing a little less. Please be sure to do an OCT on those patients. You'd be surprised to see that even a borderline increase or swelling in the OCT will land up to a fallen vision of 6/9. So if the patient who was doing well on the first post-op seems to a little less, OCT is mandatory. So you have to carefully manage, and then you intensify your Nepafenac, and you find that the little swelling goes away, patient is seeing well again. So be sure to do that. Yeah.
So the problem with EDOF, I think, is in spite of doing a micro monovision, which normally they recommend, the quality of vision is good, but the near vision is still not 100%. And that's where we still prefer doing a trifocal. And in the trifocal, barring aside a little glare and halos, which the patient does get accustomed to, I think the newer trifocals are still coming in, like the Acriva. The Acriva Trivia, they say that it has 12 steps, which are the diffractive, stepless diffractive zones, as compared to the trifocal from the Panoptix and the Zeiss. So I think we are coming to that era where even the glare and the halos and the light distribution is improving with the trifocals to almost 92 to 95%.
Sir, can I ask a question to VC, sir?
Yeah.
Is there, or any of the panelists, do you have an experience of AT-LISA in one eye and Panoptix in the other?
Oh yeah. When we shifted over from the trifocal, Zeiss trifocal to Panoptix, obviously some of the patients who had the AT-LISA in one eye had to be implanted with the Panoptix. I tell you, both the lenses, they function extremely well. I think with the modern technology of trifocals, the halos, glare, and reduced contrast sensitivity has been practically taken care of. And if you work up your patient well and choose your patient well, you should not land up with a very unhappy patient.
Thank you, sir.
So, Pranay, there is one more study which has compared the AT-LISA with the Panoptix, and they have found that both the lenses work equally well. It's just that Panoptix works a little better at 60 centimeters distance because of the defocus curve, which is a little better with the Panoptix compared to the AT-LISA. Otherwise, both are working very well.
So yeah, the other point that I want to bring out is the addressing the astigmatism or a pre-existing cylinder. No matter how small the cylinder looks pre-operatively, we calculate for every patient the toric IOL power required. And even if you have a small degree of astigmatism, we prefer to put in a toric trifocal rather than just leave them or wish that the incision would take care of the astigmatism. So we calculate for every patient the astigmatism or toric IOL and put in a toric trifocal if required.
Fully endorse it, because even a small degree of toricity leaves an unhappy patient in your hands. And the interesting thing is, when you first do the scan, it doesn't seem to show a toricity. The moment you start calculating the exact power based on the formulas, a toricity comes to be seen. So I think it's very important that we do have to calculate all these patients.
Sure.
Thank you. Thank you.
I think,
sir, there are
Swapnesh,
few
should
questions
we
in
go
the.
ahead?
So can you
Yeah,
hear me?
but
Should we take
yes.
the question now or later?
Yes, sir. So there are the questions, some of them have been answered actually, because lots of questions regarding about the toricity or different IOLs in different eyes. But Swapnesh, one or two questions, whatever you say, sir. Nitin sir, Keki sir, whatever you decide, can whatever everybody decides.
Sir, there is one question from Aurora, Dr. Aurora. Experience with monofocal in one eye and multifocal in the other eye. Any of the panelists?
Yeah.
Oh yeah, traumatic cases, we do get uniocular cataracts, we do get our aging population sometimes has an advanced cataract in one eye and probably no evidence of cataract in the other eye. In a young patient, the challenge is, and that you have to kind of condition the patient or talk to the patient before the surgery, is that you are going to compare the artificial lens with the natural lens. And there's no way you can beat the natural lens. So, but the trifocal will probably be much nearer to a natural lens than any other lens. In an aging population, you have the advantage of the near with the trifocal lenses, and they appreciate it much better because they can see and read and do the computer without the glasses.
So I feel that it's not a bad idea to put in a trifocal in one eye and a monofocal if it's already there. And then if the patient still feels that he's not happy, then maybe you can use an add-on trifocal, which has now come in from Rayner. And probably that would be the future if they want near vision without glasses. And if they are not happy with one eye mono and one eye tri.
So, we've been discussing all this, and I do agree that the latest IOLs are very good. But there is a question from Dr. Jagdish Shah, and in my mind too, that it is quite expensive. So there is a range of patients who wouldn't be able to afford. So what do you think about Indian multifocal, or is there any trifocal available? And what do the panel, all of you, think about the Indian IOLs and the cost factor?
So the Indian multifocals are also very good. We have the Indian trifocals available, and one of the best ones I have used is the Biotech, and the Biotech works very well. Also, there are others from Appaswamy, which has also got a trifocal as well as the EDOF. So according to me, they work equally well. Probably the other panelists would also highlight their experience.
No, I fully agree with you. I use care group lenses also extensively when patients can't afford the size or the panoptics. And yes, the quality of vision is pretty good. No question about it.
Yeah, Ragini. So I think
Yes.
those are a very good option. It's
Thank you,
not
sir.
that we have only Zeiss or the Panoptics. We also have all the companies making really good IOLs now.
Thank you, sir. There's another question. Dr. Ram Patel wants to ask whether when is the synergy lens going to be in the market? And other questions about different IOLs in both the eyes, one enhance and one panoptics and all. So I think those questions were partially answered, that even with different companies, patients do well.
So synergy lens is basically a combination of a trifocal lens with a EDOF lens in a single lens. So the technology is of eclect design, and they are combining both together. So probably it should be available soon. And the idea is that they want less of glare, halos, and to get the best of intermediate, near, and distance. So probably it should be available very soon. But as of now, it's yet not come into the market.
Yes, sir. Thank you, sir.
Can I add a small point here?
Yes,
Sure.
sir. Please, sir.
Yeah, in treating your patients with trifocals or panoptics, I think the biggest challenge is to hit emmetropia predictably every time. If you go to see your monofocal patients, it's just about 60 or 65% of your patients hit emmetropia. So hitting emmetropia with your biometry and whatever that you do is the biggest challenge when you start implanting a trifocal lens. You better kind of improvise or improve upon the predictability of attaining emmetropia in your present set of IOL power calculation.
Let me give you a little. Let me give you a little suggestion, which is what we utilize. We do the scan twice, print it twice, and then do a topography. If it doesn't match with the topography, then the tests are done all over again until they finally decisions match together. Because invariably, you need to know where it is. What happens is the patient doesn't fixate properly, and that's the reason why you get that 0.75 variance. And the other important thing is the day you have a patient which does not come down to within a half diopter, all your staff who do your tests are called in front and said why all the previous records are pulled out, and you have to make a big natak about it. So they know, okay, you are not going to tolerate any variation.
Yeah.
Other reason why this occurs is because the staff gets lazy. You know, you work the whole day, sham ka time ho gaya, bhai talo na bhi bahut ho gaya. That is where it occurs. So if you make a big, I mean, you have to be sure, because patients come to you, pay you a small fortune for that reason, and they
Yes, sir.
expect to get a good quality of results.
Yes, sir. So I think what you said about topography is very correct. We had a very bad experience. A patient was referred to us, a very big man in Mumbai, a priest, and multifocal and piggyback and everything, but topo was not done. And successive topos that we did, now the patient has 95% keratoconus.
Oops.
And so topography, I think if you have the machine and if we can doing so much, like you said, you know, it's important. So very, very important. So one more thing is that there are 2-3 more questions that do photopic and scotopic pupil size matter in these lenses? And if a patient has a very, very small astigmatism, say 0.5 diopters, then do we do a plain multifocal or a trifocal or go for a toric? So these are the 2 questions which are in the chat box.
If you excuse me, madam, can I make one point, madam, before we go on?
Yes. Anis, please.
That's why I emphasized in my talk that I have 2 biometrists who are blind, who do not know what the test has been done. Because, sir, what I found is optometrists, they remain the same. You have the best one or the worst one, they remain the same. They do not understand the value of doing that test. So I have 2 blind biometrics. They don't know what the other one has done. Then I cross-check both of them and check both of them and take an average of the 2. I found that to work in my practice.
Good idea.
Thank you so much.
So what Ragini you mentioned, what you
Nitin.
mentioned about the astigmatism, I think 0.5 diopters you can avoid doing a toric, and you could just do on the axis incision, and that should also work. But something more than 0.75 or 1 diopter, probably you should target to emetropia with a toric lens.
I
What
think
is your opinion?
Yeah, exactly. That's what I am trying to tell you is we do all these tests and calculate the spherical IOL power. And we are just one step away from calculating the toric power. We have all the measurements that we have the internet, we have all the formulas, and you just have to go into a toric calculator, and without thinking whether this guy needs a toric or doesn't need a toric, it doesn't do any harm to calculate a toric power, just like you have calculated the spherical power. So my take is that calculate toric power for every patient. Stop guessing which patient would require toric or which patient would not require toric. The advantages are, number one, you can show to your patients that, look, you need to have a toric IOL and toric or panoptics. If you feel it's too costly, let's leave aside the astigmatism. You'll have to wear a toric spectacle power, just monofocal toric spectacle power. So my take is to calculate rather than guess whether this patient is going to need a toric or not need a toric.
I feel the challenge is more in when you get a difference in the axis cylinder, the power of the cylinder many times.
Yeah, you
and
have
that's
so many.
where
Yeah,
even if you have one equipment, like IOL master, and if you put the patient on the pentacam or an OPD scan, you will find sometimes there is a difference in all three. And that
Yeah,
is where sometimes you don't know what to choose.
correct.
So
So
that point is
we
important.
now have formulas where you can put the 3 keratometries in one this thing, and it will calculate on an average. And secondly, the axis is more better given by a topographer than by a keratometer, whether it be auto or a manual, whatever it is. So utilize all the instruments that you have in your practice. You can utilize them in calculating your toric power as well.
Right.
Thank you, sirs.
I
So
think
should
we should move on to the next part now.
Yeah.
That is on markings of toric. Swapnesh, can you announce the next
Hi,
part?
Swapna.
Yes, yes. So there are many questions. I will note it down and ask the panelists and then circulate the answers.
Yeah.
Sure. So the next session is about planning the toric IOLs, and the first talk would be delivered by Dr. Suvira Jain. She would be speaking upon targeting toricity without much of gadgets, and then Dr. Kenia would be speaking on targeting toricity with all the
Can you see
technology.
my face first?
Yeah. Dr. Suvira, your mic is unmuted, so you can start
Hi.
your presentation.
How do I get to the screen though? Share
You
screen?
are on the screen.
Oh, all right, thank you. Okay.
Kenya sir, can you just say hello so that your
Open full screen. Where's the top first slide? Are we good for me to start now?
Yeah, please start. Please start. We will
Okay.
restrict to 8
Yes,
to 10
I will.
minutes.
Surely.
Yeah.
Right. So today we no longer need to, just settle for any residual astigmatism in our cataract surgical practice today, because we have at our disposal tools, techniques, and technology, all of which we may not actually have on our own campuses, but we can outsource these patients, send them there, or get the equipment in. And with the available technique and technologies, we are able to now end up with much better post-operative outcomes. I'd like to share with you today the finer points that would work in improving and adding the precision and accuracy to your toric IOL practice. Now, what are the main things? The successful toric IOL implantation hinges on 3 most important factors. Okay, one is the accurate acquisition of data and IOL power calculation. The second is having a foolproof and an optimal technique of axis marking on the cornea. And finally, getting the appropriate surgical technique to get as good as possible bang-on alignment of the IOL to the correct axis, right? So let's come to data acquisition. The first and foremost, what's absolutely important is the keratometry. Now, in its essential form, the keratometry is made up of 2 elements. You've got the magnitude, which is the quantum, which is measured in diopters, and we have the direction, which is the axis or the vector or the meridian. It is absolutely imperative that we have an accurate identification of both the magnitude and the vector so that you can therefore then optimally correct it. Okay, so how do you end up calculating the magnitude of astigmatism? Swapnesh insists that I speak about, the minimal gadgetry, so I'm going to stick with that. Now, a well-calibrated manual keratometer is considered by many to be pretty good and accurate in getting the correct case. You could use the case of an automated keratometer. And since we are looking at premium IOLs like a toric IOL, we should try, and at least if we don't have an optical biometer at hand, it would be well worth sending it to Dr. Deepak Bhatt. Or now we even have these guys coming into our clinics and hospitals where you can have access and get the magnitude of the astigmatism done. So these are the 3 instruments to get the magnitude of the astigmatism. Now, ideally, as Dr. V.C. Mehta just said, that corneal topography is probably the best method of getting the vector or the axis because it gives you a graphic representation of the vector axis. Okay. The other way in which you can get the access, which also works equally well, is the optical biometry. So the question now is, I think it's very important to understand the importance of having a corneal topography. It is mandatory in patients that you're planning for a toric IOL, because I think it's very important to rule out irregular astigmatism, because if you did have an irregular astigmatism, you might end up compromising the end result. I'm not going to go into details of this. This is the patient with against astigmatism. This is the patient with astigmatism. We need to, if we can manage a good topography, look at the EKR map for a tall spike. This is a patient of irregular astigmatism, but the presence of a spike denotes on the EKR map that you've got the possibility of distribution of the dioptric power along a particular axis, and still you may be well in doing a toric IOL, and not so in this particular case. So now, with all the different gadgetry, whether it's you're looking at a manual keratometer, basic, auto-K, an optical biometer, a topographer, eye trace, I'm not going there, but even with the basic instrumentation, which and how do you decide which you need to choose? Now, we do know that all the different equipments are pretty good, but all of them measure in a different manner. And therefore, the results from each of these equipments is not going to be exactly the same. Even though they are slightly different, you look for a concordance in the results between the three. And that's what Warren Hill came up with, what he considered his triangle of agreement, wherein data is acquired from 3 different instruments. And that data, the results from those 3 instruments is compared. And you look for some similarity in the results of at least 2. If you don't get it, you then go ahead and repeat the tests on those same equipments, and you look for a concordance in at least 2 of them. Okay? And so till now, when I spoke to you about measuring the case, we were talking about the anterior case. It's worthwhile just touching upon posterior corneal toricity, because it baffles those who don't know anything about it, but it's not all that frightening. It was postulated by Douglas Koch when he came up with the Baylor nomogram, and when he suggested that all adult patients have roughly posterior corneal toricity of, and against the rule of a magnitude of 0.3 diopters. So 0.3 diopters against the rule is what is suggested. Now, if that is the patient's normal posterior cornea, that means when you're correcting a patient with a width rule that is a plus at 90, and you don't take that into consideration, you're likely to leave the patient overcorrected by about 0.5 diopters. Similarly, a patient with against rule astigmatism would be left undercorrected by almost up to 0.3 diopters. So therefore, the very important distinction, as you were already starting to discuss earlier, is that what should be your cutoff for putting in a toric IOL. I completely agree today. You put all patients on a Barrett toric calculator and see what they suggest and try and correct it to the best possible, because the patients are going to be happy. So what my cutoff generally is at our institute at Haji Bacholi Hospital is that if there is a patient of a with the rule astigmatism of 1.25 and above, and against the rule astigmatism of even as less as 0.75 diopters against the rule, I would consider a toric IOL. The other way in which we can evaluate the posterior cornea is by using the Barrett toric calculator. Now, there is a place in the Barrett toric calculator, which I'll come to a little later, where it just, you click on the predicted posterior case. Now, once you take the Barrett toric calculator, which is a free online calculator, and just ask for the predicted posterior case, it does the math and calculates for the posterior cornea. You don't need to do anything else. You just go with the default predicted posterior keratometry. Now, coming to total keratometry, I think Dr. Kenia will touch upon it in detail. This is a new thing on the block, wherein they actually, with the swept source OCT of the IOL Master 700 and a telecentric measurement of the anterior case, they work out the anterior K, the pachymetry, and they figure out what the posterior K is, and they give you a full TK value, which is the total keratometric reading. Only then the formula you use is not the Barrett Universal 2 or the Barrett Toric, but you use the TK formula for that. But we don't need to go there now. I think Dr. Kenia will. Now, coming to IOL power calculation, though I would like to emphasize the need for using an optical biometer, try to get hold of an optical biometry. You don't need to own an optical biometer. I mean, we do it virtually now, but even if we didn't, till we did, we used to send our patients to Deepak, but we took that extra trouble to try and working out, getting the most perfect scans. And then you could go onto an online calculator, which is again free. Now, this is the Barrett online calculator. It is a free online service that is available. You go on there and fill the patient data. You need to have, so it comes by default. It works with a keratometric index of 1.3375. It works on a positive cylinder. You got to write the doctor's name, the surgeon's name. And when you look at the IOLs, right? It's not shown here, but the IOLs are just a fix. They only have the Alcon, the J&J, the Bausch & Lomb, the MiniWell, the Hoya, and the Zeiss, I think. So if you're using a lens other than that, all you need to do, as Graham Barrett himself told me, is you fill in the personalized A constant for SRKT for that particular lens here. And there are 3 things that have to be filled in by you. One is the flat K and the axis, the steep K and the axis, and the optical ACD. Oops, the optical ACD. Remember that the SIA, hang on, the SIA, the surgically induced astigmatism, we no longer put a figure of 0.5 because when you take the entire vector analysis into play, it shouldn't ideally be more than 0.12 to 0.2. I tend to write a 0.2. Place your incision location and go ahead and calculate. Now, the point I want to make here is important. Suppose you've got a patient, you've done an optical biometry, and even with the IOL Master 700, you don't get the axial length. Now, in a patient like that, you can take the case from the optical biometer, the ACD from the optical biometer, and then do an immersion scan. And only in the place of the A constant, you put in the ultrasound A constant, which is given on your lens, and then you can calculate as well. Now, what's important to know, so you need to know here also is that it uses a Barrett Universal 2 formulae, and you only need to feed in the K, the axial length in the ACD. You don't need to fill in the spherical. The Barrett toric calculator works out the spherical to you. It suggests which is the model to be used. It suggests the orientation. It gives you a series of 3 different lenses and the model, but you don't have to blindly go with what is the highlighted one. Because remember, there's a school of thought where people actually hope to leave the patient eventually with a with-through astigmatism of about 0.25 because there's a tendency with age to and against the astigmatism drift. So you choose for yourself which is the lens you want. This is very important to see what is the consideration, what would be the residual refractive error that you would get here. If you were to choose, people are very comfortable sometimes just with the company calculators. It doesn't work so badly. They almost work in concordance with the other. But suppose you went with the Barrett toric calculator and the Alcon with the Barrett incorporated calculator. The difference is that in the Alcon toric calculator, you have to fill in the spherical, which you worked out either on immersion or preferably an optical biometer. And you also have an option of using the Holiday 1 formula there. But I think for those who don't have anything, you can just go online and choose your IOL power. That is the first part of it, the data acquisition and the IOL power calculation. Now, I think it's very important, this is a point that can be discussed by all of us, that what is the ideal technique of marking the axis? I personally do not have access to the microscope mounted Varion and all those systems, and I personally do not even think it is required. This is a technique that is taught to me by my friend, Dr. Venkatesh from Chennai, and I don't believe anymore that using pens is a great idea because the dot of the pen itself is almost 5 degrees and that itself can cause significant amount of an error in the calculation. This is the axis marking technique wherein we use an inkless marking using a hockey stick on a slit lamp of the Hag Street model. And please note, you've got this entire gauge there. You make a very thin slit, which should be 14 millimeters long, and you can choose to mark directly with the patient suitably seated on the slit lamp, your incision site, as well as your axis that you mark. And this is how it's done. In this particular case, the surgeon is aiming to mark his axis directly at 130 degrees. You make a slit beam, bring it to the center. You know it's at the center because the middle glow just, it just glows in the center. And see, with a hockey stick, you've just made a very thin indentation onto the epithelium. There is no epithelial loss. So you're not worried about healing post-operatively. This is the technique I follow where I mark the 0, 180, making sure the patient is seated horizontally, and then I extrapolate it onto my surgery itself. I think there's no more need for all those gadgetry where you do free marking with him sitting and adjusting the head. This works brilliantly and always gives me very, very good results. Coming to the third part of my talk, where we speak about how to achieve an optical surgical alignment. Now, what you need to know is that when you use a device to correct toricity on the cornea, the device, when vectorially you view, has to be one that induces an astigmatism of the same magnitude but of an opposite direction. So correcting here in the blue arrow, you can see when you're aiming to correct a +1 at 90, you need a device which actually induces a -1 at 90, giving you the best end result. And now I come to just the surgery. A few tips about that. Now I take the 0-180 that has been marked on the slit lamp. This lasts for at least 6 hours. So even if you operated the patient 4 hours later, it would be okay. I don't wash the eye because sometimes then the fluid pools here. I would keep an appropriate and optimal Mendes axis marker and mark the 0-180, maintaining intermittently my gaze at 0-180. Don't press down because the conjunctiva bulges up. Having done that, you then move a little ahead to mark your main incision, which is, wait, where is it? Yeah, no, I'm sorry. You mark the main incision, which is at 65. And finally, the surgeon here is now marking the axis with the help of a Sinskey dipped in bluing, which is at 100 degrees here. Now, having got the main incision marked and your axis marked, you proceed with the surgery. I've often wondered where your incision would be, but today this is what I do and I teach, that you actually bisect the incision. The incision is 2.8 millimeters wide. So you want to bisect it at that point of the marking. Ensure then that your capsular axis is circular. Then you proceed with phaco. And here it's being done in a direct chop technique. Of course, your surgery needs to be meticulous with minimum energy delivered into the eye in a controlled fashion. And after you've done your irrigation aspiration for the complete removal of the cortex, now we are placing, this is a multifocal toric IOL. The toricity is on the posterior surface, and you can see those dots that show you where exactly the lens needs to be placed. And it is injected like any typical lens. Here it's done through a 2.8 incision. And as the lens is gradually unfolding, it will be worthwhile to rotate the lens such that the axis is just short of just before. If you're going to do a clockwise rotation, it's extremely important to wash the viscoelastic from behind the lens so that with a view of pushing the lens behind us close to the posterior capsule. And finally, when you have aligned it properly, this is what you need to do, a 4-point of fixation. Please note the first and the third Purkinje images, bring them together, and when they are aligned with each other, you need to have, at that point, the two lines of the cornea matching with that of the IOL. And if there is a parallax, at least those lines need to be parallel to each other. Make sure that even at the end of hydration, it is well and truly aligned, because even hydration can cause a rotation in the IOL. So this would be the surgical tip. And just another point that I'd like to make is sometimes you might end up with a patient who comes with a residual cylinder. Now, what do you do then? You dilate the pupil to make sure that the eye looks, that whether I do not routinely dilate all my toric patients on day one, because if I've got good vision, he's 6'6", part 6'9", the AR doesn't show too much of a cylinder, and he's happy. Now, even if the one point I'd like to make is, okay, you've got a post-op surprise. There could be all the various causes of having a malalignment. But before you decide that I'm going to go in and sort this out, look at what the spherical equivalent is. If the spherical equivalent is close to 0, which means the image is falling in the stern of conoid, and the patient is happy, I would think twice before doing anything. And since I have to talk about what are the ways in which, even without having an eye trace or fancy equipment, you can just go to astigmatismfix.com. It's again a free online site where you can just feed in your data, and then it guides you. 1, whether the lens needs to be rotated, or 2, whether even after rotating, you're not going to be able to address the cylindrical correction that is left behind, and it's the wrong choice of an IOL, and whether or not you need to explant it. And finally, if you've got a misaligned IOL, now this is a smart toric IOL, which was supposed to be placed at 0-180, and clearly it's 16 degrees off target. If I need to rotate a lens, I again make sure I've got the 0180 marked on a slit lamp earlier. I go in, I do tend to give at least a subtenance block because I think eyes operated tend to be sick eyes and they're very sensitive. And I don't put in viscoelastic, I maintain my positioning just with the irrigation. And here the IOL is just rotated into its position, ending up with what would certainly be a happy patient at the end. I guess with that, I come to my presentation. I hope I've kept to my time, and thank you very much for this opportunity.
Thank you, madam, for a very detailed presentation. Without much ado, I would like Dr. Kenia sir to start his presentation. Madam, can you stop share your screen?
Oh, okay.
Suvira.
Yes.
Yeah.
Yes. Is someone saying something?
Yeah.
Same things.
Suvira, you'll have to.
Yes, hang on. I have to stop share screen. How do I stop?
It's at the top of the screen.
Oh, yeah, that's it. Stop share. Pause share. Yeah, that's fine. Thank you. Done. All done.
Yeah. Okay. Thank you. And it's still on. You'll have to.
Stop. Got it. Stop.
Yeah. Okay.
Over to you. Now I just
listen. Thank you.
Sir, you're audible. You can start.
Okay. At the outset, good evening to everyone. And I thank BOA. Okay. I thank BOA for giving me this platform of taking this topic of targeting the toricity with technology. Now, as Suvira rightly said, capturing the data is the first step, may it be with the optical biometer or the keratometer. The most important thing is how to execute the good captured data and execute it during the surgery is the most important thing. And that is when the technology comes in. So why do we use technology? To give us precision? Because as VC sir said, that in premium IOLs, we don't want more than 0.5 diopters of astigmatism. Yeah. So with precision, we want astigmatism near neutral, a spherical power near neutral, and it should be convenient, easy, fast, and error-free. And it should be consistent. So technology is here to overcome the fallacies of manual IOL marking. Suvira highlighted a very good marking on the slit lamp of toricity. Ideally, slit lamp marking with the toricity is very well to be done on the slit lamp. But the most important thing is the head alignment. Before you put the patient on the slit lamp, you have to see the lateral canthus are at the same level. The vertical misalignment, the chin and the temporal, head should be aligned well. Even if there is a vertical misalignment, it will cause a problem. The cyclotorsion error is something which is not compensated in the manual IOL marking. Thick marking with a pen should be substituted. I usually have shifted to a markless system, or I would use the keratome, the main incision 2.4 keratome or a 2.2 keratome. You can use a side blade to mark the incisions on the cornea. Parallax errors have to be taken care of. Transcription errors, sometimes you have captured the data, but because of, say for example, an axis of 110, and if you feed in 10 degrees, it causes a transcription error, and the whole alignment of the IOL or your whole surgery may have gone beautiful. But because of this transcription error, the outcome is bad. So tedious process of calculating and planning the SIA, and mind you, technology gives you a personalized A constant, which is optimized again and again. Your SIA, not only for your right eye and the left eye is different, but also for the temporal incisions and superior incisions are different. So this, everything is personalized in the technology. I use the Virion imaging system, and it delivers consistent and precise outcomes, but not only consistent and precise, but it helps me to give a speedy outcome. So most important part of Virion is not only accurate marking compensating for the cyclotorsion, but it also helps us, as Dr. VC Mehta again said, that each and every case you have to see whether it's a toric or a non-toric. Sometimes a non-toric you may feel, but when you put on a planning software, you come to know that this requires a toric IOL. So it's very important to put each and every patient on a planning software which is incorporated in the Virion. Not only that, it also gives you a consistent capsular axis. Mind you, a consistent capsular axis size centered on the visual axis is very important for the ELP, or the effective lens positioning. A personalized A constant. And most important is an uninterrupted OT surgical list flow. Means if I have a toric lens, I don't have to wash out again, go in and mark and come back again. So the flow is smooth. One case after the other, it doesn't matter at all. So Virion definitely helps that way. Whether it may be a toric case or a non-toric case, I do Virion for all my cases. So what does a Virion digital marking system do? It captures the K values from 0.8 to 3.2 millimeters of the cornea, and the axis is measured from the central 2.5 millimeters. It does the planning, and the registration is done using the iris pattern, limbus, and the scleral blood vessels. So the image of the cornea taken is then superimposed in the OT, so that the cyclotorsion compensation also can occur. So what are we talking about? We are not just talking about measuring the astigmatism. Measuring the astigmatism, as Suvira said, is part of the job. But integrating the whole thing is the most important thing. Integrating and executing to the exact astigmatism, to the finesse, will give the best outcome. So first part of Virion is capturing the data properly. Virion is so sensitive that if a dry eye patient is there, it would not capture the K values. So it tells you that the K values are not very good. You have to call the patient again at another day. So unless the data is really good, it would not capture. And at my center, I compare it with the Pentacam, the IOL Master, and the Auto K. So definitely comparing the K values also helps. The second thing is the planning. Once the planning is done, what kind of incision are you going to put? Where are you going to sit? Temporal, superior, or what are you going to do? All that is planned, this thing. And the third thing is that it not only helps intraoperatively, but also post-operatively, whether there is a malposition, surgical optimization which has to occur, it gives you a personalized A constant. So which from time to time gets revised. So you know your even surgical induced astigmatism has changed or not. So definitely, as Suvira said, that with the concept of the Barrett centroid system, we just push in a 0.2. But mind you, a surgical induced astigmatism is more dependent on the corneal biomechanics, and it varies from eye to eye. Now the Virion guided system definitely helps not only to guide us where the incision has to be placed, because even the placement of the incision is very important. And with everyone nowadays doing topical cataract surgery under topical anesthesia, the dynamic rotation of the eye and the tilt also plays a role. So your incision site may sometimes vary. So with the new generation Virion software, it has got a plumb line inside. So it compensates even for the head tilt. Capsular axis, definitely it helps. I use a consistent capsular axis of 5.5 millimeters, and which is centered on the first Purkinje image. A 5.5 millimeters capsular axis is done. It not only helps for the toric IOL placement, but also for the centration and finalization. And the centration and finalization is the most important step. So this is how the measuring of the toricity is done. But as Suvira said, total K versus the anterior K measurements, I still did not find much of a difference between total K and anterior K measurements. So I am still sticking to the anterior K measurements so that I can, compare with the other instruments, the Auto K, the IOL Master, and the Virion. And the most important is whenever you get a toric case, you do a topography. To ascertain whether the astigmatism is regular is very, very important. If the astigmatism is irregular, you may have a surprise. So this is how I do my cases. I first put the patient on the IOL Master 700 and then move on to the Virion. On the Virion, everything is planned where the incision is going to be. I do not use the LRI. I totally rely on the toric IOLs for neutralizing my astigmatism. Technology is there today. Femtosecond cataract machines are able to do a femto LRI, but still most of the panelists today, Dr. VC Mehta will share his experience, but I still feel toric IOL is the best way to neutralize the astigmatism because it's more consistent. So once the toric IOL planning is done, we then choose the model of the lens to be implanted. We definitely have to be very aggressive with against the rule astigmatism and aim for emmetropia. For with the rule astigmatism, you aim for a slightly under correction of minus 0.25 of astigmatism. So intraoperative tips is a good CCC. Remove all the OVD, no overfill. And once you have aligned the lens, after hydrating the wound, again check whether your alignment of the lens is proper or not. And once you remove the speculum, again check whether the alignment of lens is proper or not. Because the most of the rotation of the IOLs occur in the first 1 hour itself. And beyond 1 hour, the rotations of the IOL is very, very rare. So which are the cases where rotations is anticipated? These are myopic eyes with large capsular bag and long IOLs. In such cases, usually I have burnt my hands with a plate haptic trifocal, the acrylisa, where the Zeiss IOL tends to rotate. Here, using a panoptics definitely is advantageous because of its C-shaped haptic, the stability is much higher. Even after putting an endocapsular ring with a plate haptic Zeiss trifocal, rotation was still there. So when do you rotate, take these patient up for a correction of the orientation of the IOL? You usually tend to wait for at least 2 weeks so that the capsular bag warpage occurs and there is slight amount of adhesion. Because if you take them immediately, again the IOL will rotate. So it is definitely better to wait for some time, assure the patient, tell him that there is nothing much of a problem. There is a slight rotation which has occurred and we would tackle it, say after a week's time. By the time some capsular bag adhesions would have occurred, and then the lens, whatever you have rotated, would have been better. I have rotated the lenses even after 1 month. It's slightly more difficult, but it is possible to do it. You can rotate, but generally try to finish your rotations of the lenses within the first 1 or 2 weeks. Now, the most important thing is post-operative residual error. Whenever I get a surprise, like Suvira said, the spherical equivalent is 0. Yeah, that is right. The spherical equivalent is 0. Most probably the astigmaticsfix.com would tell you that rotate the lens so many degrees and you'll be able to tackle it. But the most important thing is how much is the misalignment. To calculate the misalignment, how much it has rotated off. That is the most important thing. For that, the OPD scan and the eye trace are the best instruments to gauge post-operatively. You can do that grossly also on the slit lamp post-operatively to know how much the IOL has rotated. But the most refined way of using the technology and doing it is using the OPD scan and the eye trace. So what are the options? So it is just pure residual astigmatism. You can use the limbal relaxing incisions. And if there is a spherical as well as an astigmatic component, you can do laser vision correction. You can do a PRK or wait for around 8 weeks and do a LASIK. Or there is a gross residual error, then you may think of doing an IOL exchange. But most of the times you can get away with just IOL rotations and laser vision correction. IOL exchange maybe, but I have still to come across a patient where an IOL exchange would have been required. So these are for IOL rerotation. You can use the astigmaticsfix.com, and the Barrett gives you a new formula, the Barrett RX formula, which also helps you for these residual astigmatism. So now what has the literature to say between manual and digital? See, manual marking is not inferior. The problem is time. In a busy OPD, how much time can you devote as a clinician yourself, marking and doing the thing? That is important. So in my practice, I had to move on and shift to technology to help me out to tackle this problem. So in my practice, Virion has helped me a lot. It has helped me not only capturing the data accurately, but also flawlessly executing the planning of the IOL astigmatism as well as the surgical execution. So most of the papers say that the manual and the digital marking, there is not much of a difference. Hardly a minus 0.3 to 0.4 this thing. So if manual marking done properly, definitely on the slit lamp is a good idea. But there is something known as Toric cam also introduced by Barrett. You can use this. But what I want to say is that if you are doing a lot of premium IOLs in your practice, most important thing in a premium IOL practice is hitting the emetropia every time. Not you want to tackle the residual astigmatism of minus 0.5, minus 0.75 also. And in those cases, you have to be consistent. And to deliver consistency with speed is where the technology comes in. So technology, though expensive, is worth in a busy practice. Technology helps in delivering consistent near emetropia without much ado in toric and multifocal lenses. This is a short video. See here, I mark the incisions with the keratome. I'm not using any marking pen. You can use the markless system also, but I prefer to mark it before starting the cataract surgery, so I can sometimes then not rely on the system. See, most important point which I want to highlight here is, even though the IOL is not aligned properly, I'm rotating almost 180 degrees again. I'm not going anti-clockwise. Always rotate clockwise.
All the big shots like Warren Hill and everyone, they also hit 0.
Clockwise rotation is the most important thing. And the other point is that once you have hydrated the wound, do a gentle hydration of the wound so that the IOL does not rotate. And check for the alignment even after hydrating the wound and after removing your speculum. Thank you so much.
Thank you, sir, for your presentation. I would like to ask the panelists, the experts, the chairpersons to give their comments on the same topics. VC sir?
So,
Very nicely done presentations by both the speakers. Just a quick overview of what is very important in executing a toric IOL. Whatever you do, whether it's the measurements, it's the marking, the head position is very, very important. So if your head is tilted, you are measuring everything in a different axis. So whether it's an automated measurements or automated systems where you have the image guided systems, everywhere you see the head position plays a very, very important part, whether you do a manual marking or whether you do an image guided marking, number one. Number two is very important when you align the IOL in the intended axis. First, you remove the viscoelastic from behind, and complete removal of the viscoelastic is very, very important. And number three is a good sealing of the side port incision. Even if there is a little bit of leakage through the side port, mind you, and there is a little bit of viscoelastic behind the IOL, as the chamber shallows in the post-operative period, the lens rotates over the blob of the viscoelastic. So both these things are very important. Leakage in the post-operative period to be absolutely zero, and viscoelastic behind the IOL has to be absolutely nil. And as far as the examination post-op is concerned, we take the vision, and if it shows significant amount of astigmatism, then we put the patient on the eye trace, and we take a decision little late, about 4 to 6 weeks, of deciding whether to rotate the IOL or not.
ADS sir, your comments.
So the difference between manual marking and digital, like I have just recently moved to the digitals in the last 3 months, and there is a good bit of difference. Means you find that you are on the dot with the Callisto system, what I've been using now. And I find that my astigmatism post-op has gone to less than 0.5. And one other tip I would like to give is, whenever you feel that the lens, after you have implanted it, you can just put in the air bubble inside and leave it for whatever time, like just leave it inside. And you will find that that air bubble prevents the movement of the IOL whatsoever, because we know that the IOL rotates in the first 2 to 6 hours, 2 to 4 hours. So if you have just left the air bubble, you will find that there is no movement of the IOL and it stays very well in the right position. So I think this is something which I have observed. And another thing is, if it has rotated, then when to again align it. So
yes.
that is also something which one has to decide. But normally, if it has rotated, it is always better you wait for a day or 2 days or even more, because by that time you will find that if it has to re-rotate again, it will not. And because of the capsular contraction, because the anterior and the posterior lips, they come together, and then at around 3 to 7 days, anytime in between, if you rotate it, then there are less chances of it again moving from its position.
Swapnesh, I have a few comments, if I can.
Yeah, please go ahead.
Can I? Sir, is it all right, Dr. Mehta? Can I just speak? A few
Please.
comments.
Yeah.
So one, I think, one point I'd like to make is that we all speak about getting close to emetropia. But even Warren Hill, Douglas Cock, all of them, they claim that if in up to 80, they themselves are even looking and struggling with their own formulas and aiming to hit 0.5 in at least 80% of their cases. And that I think is realistic. I mean, even if in 80 to 80% patients, we can get up to 0.5, even if it's 0.75, if it's reduced to what it really was, I think you would have achieved a good end result. Second, I agree with Dr. Deria that I wouldn't wait for 2 weeks to rotate the lens. Once the lens bag gets sticky in about 2 or 3 days, if I can clearly see on slit lamp that my lens is not at the correct axis, by again doing a slit lamp examination, once the edema in the wound settles, once I know that the Ks are settling to whatever they are, again in about 3 or 4 days in my hands, I would look at what the astigmatism is, and I would be a little more proactive in making that rotation. And finally, that if Dr. Kenia, I respect, I really like the way you've exploited the Varion for everything. But I must say that even a slit lamp marking, it doesn't really take more than 3 or 4 minutes in the OPD once you get your hand set right. Moreover, the marking lasts, suppose you plan to operate even 3 hours later. I found that I'm pretty easy with marking and then running to the OT. Even if I have a list of 15 and 2 are toric IOLs, it doesn't matter when I do the toric IOL, the marking still remains exactly.
Can I answer that? Can I answer that?
Sure.
Yeah. Suvira, the slit lamp has to be in the operation theater. That's the first point. Because when you have taken up the patient here, you are in the operation theater. You're not going to come out and go to the OPD and do it.
Agreed.
So you have to have a slit lamp. So that's the number point. Second point is the flow. Say if I'm going to operate a long list,
yes,
it becomes slightly more hectic in my hands.
Sure.
I prefer the Virion is helping me.
Sure,
So,
absolutely.
and the second point which you said, the second point which you said about the stickiness, this is especially for the myopic eyes where the capsular bag is very huge.
You'd like to wait.
The rotation of the IOL is more common in those eyes than in the hypermetropic or emetropic eyes. Okay. So waiting, I didn't say just 2 weeks, but doing it within the 2 weeks. Sometimes what happens, there is some amount of striate keratitis or something or the other. You want all those things to settle down.
Yes, to
so
know what
4 or
your
5 days you have waited. So once you are sure that everything is fine, you are sure about the residual astigmatism, and then go about, because this is the only chance you're going to get. You're not going to do it again and again. So it's definitely waiting for a few more days is more better than to jump in on the third day itself.
Okay. And just one final point I'd like to make is that when you've got a refractive surprise, the patient is unhappy. And if then, I mean, even though this is beyond the scope of the talks Swapnesh gave me, if you have access to an eye trace, and I mean, and if you worked it out that rotation is not going to make any difference, which means the choice of lens is wrong. And I've addressed at our hospital a couple of cases like this, wherein when we put the patient on an eye trace and actually look for the induced abrasions, if the induced abrasions are so much because of the faulty lens in the eye, I would then opt for removing the lens and replacing it with another lens rather than doing a surface ablation, because I then have a lot of distortion and induced aberrations caused by the wrong lens and some amount of induced aberrations by the LASIK. It's just a small point that if we have access to that, it might be worthwhile making sure that the lens in there is not doing more harm than just giving a significant astigmatic residue. So it's worthwhile looking very, very closely at what exactly is going on in the eye. And even if you don't own an eye trace, Dr. Deria is there. I mean, you can send the patient there. And
can I put my point in?
Oh,
See,
absolutely.
exchanging an IOL, you would decide only because exchanging an IOL has its own risk.
Yes.
Okay. So because it's an intraoperative procedure. So if you can finish off a small residual error with an extraocular procedure, I would definitely prefer.
All right.
Because exchanging an IOL through a 2.8 millimeter incision is possible. I'm not denying that. But in the process of exchanging or through a small capsulorhexis to remove the plate haptic IOL sometimes becomes very, very difficult. So those are the challenges. Definitely, I agree with you. When there is a gross residual error, there is no other alternative but to exchange the IOL.
There is the main indication for exchanging the IOL, rather than the gross refractive error, is the recurrent rotation of the IOL. So whatever studies and literature have shown that when there is a continuous rotation, like you may have done it twice, thrice, That is where you would remove the IOL and put in a spherical IOL and then do a laser after maybe 2 to 3 months and correct the astigmatism. So these are the cases where mainly they have explanted the IOLs in toric IOL. Any other questions?
There are quite a few on the group here.
If I can just add on one more
Yes.
thing, if possible.
Yes, sir. Yes.
One of the, you always have to consider a very fundamental concept. Why does an IOL rotate? Okay, big bang. That is not more frequently than not. It rotates because when you remove the speculum in the end, the chamber flattens, the eye becomes flat, the lens moves forwards, and irregular pressure from the vitreous causes the rotation. That's personally the reason why I think so. Now, I know it sounds ridiculous. I know it hasn't been described earlier, but what I've learned from bit of experience is that after you remove the speculum, if your chamber goes flat, refill the chamber on the table, recheck that your axis is in perfect position.
Agreed.
Very often you'll notice that is where the rotation is occurring. As one more little point to add on, if you are using a panoptics, then you always blow the lens back inside the eye because there is an adhesion factor which comes there. It doesn't occur with the size because it's a plane haptic with a HEMA coated surface. But with a panoptics, if you press it down and hold the air bubble for up to say about half a minute or so, adhesions occur with the back, rotation will never occur after that. But the most important point to remember is that when you remove the speculum, be sure your chamber is not flat on a toric patient because these are the patients which tend to rotate.
So have you tried an air bubble? I think there is a recent paper where somebody has presented their experience just putting in an air bubble and letting it stay there.
Yes, you use the air bubble because the pressure, but why does the air bubble
work? With the pressure it stays.
Air bubble works because you are maintaining chamber.
Yeah.
You can either use an air bubble, which I use also, or you can just make sure after remove it, hydrate the edges at that point. Making sure that your lens hasn't rotated. Problem with the air, go on.
So the problem with the air bubble, keeping it full chamber later on means till the air bubble does not get absorbed, the patient does not see and causes apprehension inside.
No.
So what Sir said, Keki Sir said, is just put the air bubble, let the adhesions occur and then remove the air bubble.
And either way, air doesn't stay more than 48 hours.
Yeah, so it
but if you put an air bubble in, be 100% sure to tell the patient, I have put a bubble, you see a little bubble on top, it absorbs in 2 days, don't bother about it. Because the relatives will see that bubble when they put the drop and say, Andar ghum raha kuch.
And you may not put it full chamber, you can just put it just to oppose the lens.
True.
Tamponate the lens down.
Yeah.
So what I do differently is just one thing. When, of course, 1000% you're sure that you've removed all the visco from behind. If I just tap the lens in a slightly posterior position, I find the Alcon toric or even the Technis toric tends to be behind. I mean, there's no Velcro that's going to make it stick. But yes, there's a tendency, as long as you clear all the visco and push it in a backward position to the best of your ability. And I don't use air, but I tend to give a very tight eye. I tend to leave a tight eye in these a little bit more. So I feel more confident that it's not going to rotate, and it generally works that way for me.
You know, a number of surgeons now all over the world, I mean, the literature now shows that they are using what we call as injection utilizing only fluid and not utilizing viscoelastic in the end. Maybe that is one thing which should help us in the long run also.
Yes, that's a good idea. You can even do hydroimplantation under...
That's right.
Yes,
absolutely.
That would be a good idea. So there's no visco to remove then. Shortens the time, shortens the turbulence, shortens the damage to the endothelium, and ensures that the lens would stick against the posterior capsule.
And it's cheaper. And it's cheaper.
No, well, I guess. Yeah.
There is a question asking how good is the Callisto? Dr.
Callisto, I think Callisto, at least in my hands, I've been now using it for almost 2.5 years. Callisto gives an excellent result. I use it. I combine my microscope is a 700, so I get the data in my eyepieces, and it enables me to get a perfect alignment which I require. I think it makes life much easier, especially if we do volume surgery. Nothing to beat a Callisto. Other advantage of Callisto is that on the 700, when you do your calculations, it comes on a stick. and the stick you put into the callisto, so the data is automatically transposed, no problems of mistakes occurring, and most important of all, everything is on the data available for you and in your eyepiece. It certainly made my life much easier.
Yeah, I think that is the important thing, that directly the data is transferred from the IOL master to the microscope.
No transcription errors.
No transcription errors.
Yeah. Sir,
Can I
and
add something here?
Yeah.
Coming to the image guided systems, we went a full circle round. We started with the manual marking, then shifted to the image guidance, and since about 5 years or so, we are back to the manual marking. 100% all the cases are with manual marking. And mind you, I have found no difference between the image guided system outcome and the manual marking outcomes in a Toric IOL. So this is for the general ophthalmologist who would probably think that image guidance is the best. I would vouch that it's not so. Even your manual marking can be as good as an image guidance system. And secondly, maintaining the flow of the patients in the OR is much easier when you do a manual marking. And I have taught my anesthetist to do the marking, and she does a wonderful job.
I must tell my anesthetist, you're getting lazy here.
Absolutely. You make them work something more.
Absolutely.
So the point is how meticulous you are. But when the technology comes in, you are not just dependent on yourself. The technology compensates that. So definitely capturing the data.
Vaishal, I agree that technology does a wonderful job. What I'm trying to tell you is that for the general ophthalmologist, is just to drive a point that a manual is as good as the technology.
A meticulous manual marking.
Absolutely. You should know the intricacies of where the mistakes can be made, and you should follow absolutely in that manner.
So
Let me summarize by saying it's the painter, not the paint. So it depends on how good you are, which gives the results.
Well said, sir.
So I'd like to state to those watching, because the vast majority of us cannot afford all these very fancy gadgetry. Yeah, the vast majority of us cannot, and therefore I think if you understand what is toricity, astigmatism, addressing it, and understanding how good it is to consider a toric IOL in your practice with or without fancy technology. And there's so much you can do without even high-tech gadgetry. But understanding astigmatism, being meticulous in your marking and your surgery works a very, very long way.
Absolutely.
And I think everyone should consider starting with toric IOLs in their practice. If they aren't, there is nothing to fear. It's the same surgery.
And you get wonderful Indian toric IOLs now. So I think
there's no reason why one should not use a toric IOL. No.
Absolutely.
So I'm going to intervene here. I think that was a great summary, Suvira. But I think we are running out of time now. We've almost close to 2 hours. We've had a fantastic discussion on both the topics of multifocal IOLs and toric IOLs and astigmatism. When it comes to astigmatism and the latest technology, there are going to be umpteen number of unanswered questions. I can see a lot of questions on the chats, which we'll take another maybe hour or two to address them and discuss. It's a very interesting topic, but I have to close it here. And I'm going to thank all the presenters, Dr. Pranay, Dr.Anis, Dr. Vaishal, and Dr. Suvira for such fantastic, precise presentations. Very nice, crisp presentations. And my pranam and thank you to our chairpersons, Dr. K.K. Mehta sir, Dr. V.C. Mehta sir, and Dr. Nitin Dedia. And one closing remark from my side, whether COVID or no COVID, some things never change. This was the 4th BOA webinar, and among all the 4 webinars, today was the highest attendance. So when it comes to cataract and IOL, like there is maximum crowd in the halls, there is maximum attendance. Today we had 250 people attending our webinar at one given time.
Thank you.
So,
thank you.
Let's hope for such good discussions again.
Preetham?
Yeah.
Preetham.
Yes.
Let's at this moment in time understand that life has been the greatest leveler for all of us. And it's been the most humbling experience. And let us take our time to introspect, see what really matters to all of us, and give thanks to all the people who provide us with food, eggs, vegetable, and fruits, and keep us going.
Absolutely.
Absolutely. You said
Absolutely.
it. You said it.
You said it.
So
Thank you,
everyone.
Pritam.
Have a
Good
good
night.
evening.
Thank you.
And see you again on Thursday. Our next one will be on Thursday at 6 p.m. on refractive surgery.
Thank you, Preetham.
Thank you.
Thanks a lot. Thanks,
Thank you.
Swapnesh.
Thank you.
Thank you.
Yeah.
Thank you,
Bye,
everybody.
Pritam.
Bye-bye.
Bye, everyone. Dinner
Bye.
time.
Bye, everyone.
Bye.
Bye.
Pritam sir, I'll end the meeting.
Yeah, please.
Yeah, yeah.